So now let's talk about another study. This is Garthwaite, Gross, and Notowidigdo from 2018. Sorry, Notowidigdo. I don't know how to pronounce that. And this they're going to look at the relationship between hospital compensated care costs and the number of uninsured people in a state, right? So they have a state level study where for each state in each year they have how much hospitals are spending in uncompensated care, right? So this is care that the hospital is providing that they're not being paid for. And they can see how many uninsured people there are in the state. And you can notice that the change in uncompensated care is fairly strongly correlated with the change in share in uninsured people. So states that had more people lose insurance from 2000 to 2005, this is 2000 to 2005, the states that had more people lose insurance also had larger changes in uncompensated care costs per capita, right? And so this is a sort of table showing per capita uncompensated care costs as a function of the share of population. And the important number you should look at is here. I guess all these numbers are going to tell you a pretty similar story. And this says that basically each additional uninsured person is going to increase hospital costs by $800 a year, right? And that's a lot, right? So each additional person who's uninsured costs hospitals $800. That's a lot of money, right? When you're talking about, right, if you may remember, during the arguments about the big beautiful bill, Senator Josh Hawley said, if you kick people off of Medicaid, rural hospitals are going to go out of business. He didn't say, oh, people are going to lose health insurance and they're going to lose access to care. No, he said, he may have said that as well, but he specifically made a point that rural hospitals will go out of business. Why is that? My guess is that in Hawley's state, and for the people he represents, a lot of people in rural areas don't have insurance, right? They rely on this implicit insurance, which is borne by hospitals. And so he knows that when people lose Medicaid, when you kick them off of Medicaid, the hospital is going to end up paying for them. So that was sort of for this part of Garthwaite, Gross, and Notowidigdo, they're looking at sort of, they're comparing states with states where they had more people with more uninsured people and less uninsured people, right? This is a nationwide study. They also do a case study in Tennessee, right? So in late 2005, Tennessee removed 170,000 people from its Medicaid program, TennCare, right? They were they were brought in, they were given Medicaid in 1995, and then they were removed in 2005, right? And so those who lost coverage were relatively high income, they were mostly childless adults, and they mostly used an above average amount of medical services, right? So this is an example of what's going to happen when we kick a bunch of people off of Medicaid, right? I mean, this is very relevant for U.S. policy today, where, I mean, part of the idea behind the big beautiful bill is we'll pay for it by removing people from Medicaid. Let's see who's going to bear the cost. Is it going to be the people we remove from Medicaid, or is it going to be other people? So what happens here, right? So we can see sort of before 2005, uncompensated care costs for Tennessee versus other southern states are pretty similar, right? They're maybe a little different in 2000, but from 2002 to 2005, they're pretty identical. So what about what happens after they kick a whole bunch of people off of Medicaid? Well, uncompensated care costs go up in the South, right? That means there's a lot more people showing up to hospitals and getting care without being treated, right? They go up a lot, and other states are going up as well, but not nearly as high, as quickly as they are in Tennessee, right? So all southern states are seeing an increase in uncompensated care, but Tennessee, which kicked a whole bunch of people off of Medicaid, is seeing a very rapid increase in uncompensated care. That's much more than the increase in other southern states, right? So this is called a difference in difference. study design. If you've studied econometrics, you've seen this before. This is pretty textbook as far as differences in difference designs go. And we can see that after Tennessee kicks a whole bunch of people off of Medicaid, right, their hospitals start paying way more for people who basically can't pay for their medical bills. So in addition to looking at Tennessee compared to other states, they also look within Tennessee, right? So in Tennessee, right, you can see the percent change in enrollment. So the dark red means not much change in enrollment. Dark red means actually, hold on. This is okay. Sorry, no. There's also a negative here. Yeah, sorry. Dark red means more change in enrollment. Yellow means less change in enrollment. Right there should be a negative here. This threw me off. So you can see places that lost a lot of. You can see counties that where more people were lost insurance. Right, so you can see a whole lot of people here lost insurance. A whole lot of people here lost insurance. Right. Versus some counties, right? This county, barely anybody lost insurance, right? Maybe some people even gained insurance, right? And so there's also variation sort of within Tennessee between counties where a lot of people lost insurance in 2005 versus counties where not a lot of people lost insurance in 2005. So comparing counties where the sort of blue line is counties where hospitals in counties where a lot of people lost insurance. The red line is hospitals in counties where very few people lost insurance, right? We can see that before 2005, basically the same. And then after 2005, right, the places where more people the counties within Tennessee, right, where more people, or hospitals in counties in Tennessee where more people were kicked off of coverage, saw much higher uncompensated care costs than hospitals in counties where very few people were kicked off of Medicaid did, right? So what happened when you kicked a whole bunch of people off of Medicaid? Well, hospitals started, having to pay more in uncompensated care costs because people couldn't pay their hospital bills, but hospitals still had to pay for pay for people's treatments. Right, because a hospital can't let you die if you show up needing treatment. So, what are sort of the big conclusions you should take from Garthwaite, Gross, and Notowidigdo? The sort of top line number is each uninsured person costs hospitals $800 per year. Right, so if somebody's not insured, they're going to cost hospitals $800 a year. That's a lot of money, right? Because there are a lot of uninsured people. Right, Tennessee, right. Had 170,000 people who they kicked off of insurance. Each of those people cost hospitals $800 a year, right? That's when you go up to when you look at, for instance, states that chose not to expand Medicaid after Obamacare, right? That because states had the option to expand Medicaid under Obamacare, and many of them didn't. It's estimated that. Using these numbers, actually, it's estimated that states that didn't expand Obamacare didn't expand Medicaid under Obamacare, cost their hospitals about $6.4 billion from that decision in total across all the states that chose not to expand Obamacare. Right, that's a lot of money. $6.4 billion is a lot of money. Now, 40% of this cost is passed on to other patients. Right, 40% of that. Right, so when you get an 800, right. So 40% of that $800 is going to go into your ridiculously expensive Tylenol pill. And 60% is going to come out of hospital profits, right? So this is going to be enough to tip. This can be enough to, by the way, sometimes when you kick people off of Medicaid, hospitals do close in the areas where a lot of people are losing Medicaid, right? That's because a lot of this comes out of hospital profits, right? So hospitals eat most of the loss, but some of it does get passed on to other patients. These costs fall especially strongly on nonprofit hospitals, right? So hospitals, they basically all fall on hospitals that have emergency departments, because that's where for people who don't have health insurance, pretty much get most of their health care from the emergency room, as far as we can tell. And so this pretty much all falls on hospitals that have emergency departments, and a lot of those hospitals are nonprofit hospitals. So a very important takeaway from the study is that Medicaid benefits hospitals and other patients by eliminating uncompensated care costs, right? So when the Big Beautiful Bill kicked a bunch of people off of Medicaid, right? We are going to pay the price, right? Our hospitals are going to pay the price, and when you go to a hospital, you are going to pay the price for that, right? Those people will still receive health care. It's just instead of the government paying for it, right, and us being taxed to pay for it, the hospital is going to pay for it, and the hospital is going to pass on those costs to us. So that this is an example of uncompensated care and how it affects hospitals and their finances, as well as how much you pay when you go to a hospital. So at this point, you might be saying, okay, Liam, you've convinced me that implicit insurance exists, which is really weird, right? I didn't realize it exists, but it does. And it explains why I pay so much in hospitals, and it seems to be really bad for hospitals. And, maybe the primary beneficiaries of Medicaid aren't actually the people on Medicaid. This is really weird. I need to think more about it. But how much does the existence of implicit insurance affect people's demand for insurance, right? Do we have estimates on how much people are actually willing to pay for health insurance, given that they have this implicit insurance? And fortunately for you, the answer is yes. And in fact, we have already seen the paper that uncovered the best evidence on this. So this is going back to Finkelstein, Hendren, and Shepard from 2019. And last time we saw this, we saw it because they found really clear evidence of adverse selection, right? I'm not sure if this graph sparks any memories, right? But we can see, right, where health insurance plans increased in cost, insurer costs increased as well, and that's because when you increase the cost of the insurance, the healthy people dropped out. So as a reminder, sort of what's the context to the study? What are they looking at? So they're looking at a health insurance, a Massachusetts health insurance exchange for low-income individuals called ComCare. And basically, this is for people who weren't eligible for Medicaid, but Massachusetts wanted to make sure they had insurance. So they heavily subsidized insurance plans for people below 300% of the federal poverty line, right? This is a program that Mitt Romney was very involved in. He was the presidential candidate in 2012. I remember that very, very clearly. That might be before your times. They estimate demand for ComCare plans, right? And they're going to be able to see how much ComCare is spending versus how much people seem to value that care based on how many people are dropping out when the subsidies suddenly decrease at certain income thresholds. So as a reminder for how the sort of ComCare subsidies were structured, right? So we have premiums for the cheapest plan, right? Starts at you pay nothing if you're at 135 to 150% of the poverty line. If your income is between 150% and 200% of the poverty line, you pay $40 a month. If you're between 200 and 250% of the poverty line, you basically pay $80 a month. And if you're between 250 to 300% of the poverty line, you pay $120 a month, right? And so right at these, at 150, 200, and 250% of the federal poverty line, the amount you have to pay for insurance increases a lot, right? So you have a full subsidy, right? If you're between 135 and 150% of the poverty line, that subsidy shrinks to this, right? When you go up to, suddenly, when you hit 150% of the poverty line, subsidy shrinks even more to this, right? When you're at 200% of the poverty line, and at 250% of the poverty line, right, the subsidy shrinks even more. Now, worth noting, technically, the subsidies that we're looking at here are to the cheapest care for something called Celticare. So they're a little broader than the arrows I drew. But broadly the point stands, where around these very discrete income thresholds, the amount you pay for healthcare suddenly spikes, right? And they're going to be able to use this to estimate demand for healthcare, right? So just, and you can see, right, when the price goes up, a bunch of people drop out, right? And so they're going to use this they're going to use the number of people who drop out at each threshold, right, to say they're going to reconstruct a demand curve from this. And this is the adverse selection graph that we saw earlier, which I hope you all remember fondly. So sort of what's the takeaway from this study, right? They do a whole bunch of complicated analysis that I won't go through, but what's the takeaways? What should you take from this study? Low-income health insurance demand is really price sensitive, right? So we can see, right, a lot of people are dropping out at each of these thresholds, right? Particularly the first two thresholds, right? So when demand for income, when health insurance, right, you see like a 25% drop in the number of people getting health insurance for each 40% increase in the enrollment plan, right? So again, we see there's a 40% increase there's a $40 increase in the monthly cost of the plan here. 25% of people drop out. Another 25% people drop out when you increase the cost by 40 again, and then another 25% drop out the last time you increase the cost by $40 a month, right? So that's remarkable, right? Health insurance demand is highly price sensitive, right? And even modest premiums, right? We don't think is $40 a month as being that much for health insurance can be a major deterrent to coverage for low income people, right? Even small increases in price for low income people can cause a lot of them to lose insurance and to choose not to have insurance. There's also really strong evidence of adverse selection, right? Enrollees who leave have higher healthcare costs than people who remain, right? That's this graph here. And then in terms of how much people were willing to pay relative to how much the insurance company paid, it seems that people were only willing to pay about 20 to 50% of the costs that they imposed on the insurance company, right? So that's remarkable, right? So that's they're willing to pay about a quarter of the costs that the insurance company is paying for them on paper, right? And that's crazy, right? So people value health insurance at about a quarter of the on-paper benefits they receive from it. Now, why is that? Well, a big reason for this is implicit insurance, right? The uninsured, low-income uninsured people pay a very small share of their medical costs, right? So implicit insurers, hospitals, and other patients like you and me are an important beneficiary of public insurance as a result, right? And Lockwood 2025, which we went over earlier, right, that suggests that health insurance may actually be anti-insurance, especially if you're low income. So this has been the lecture on implicit insurance, right? It creates a lot of problems in the U.S. healthcare industry, right? That we have a lot of people who we give insurance to, even though we pretend we're not giving them insurance to. That's a really big problem. You will see later on, once we go over the U.S. healthcare system more broadly and more systematically, you will see an interview with Amy Finkelstein, who, again, wrote some of these studies. She's arguably the best health economist in history. Amy Finkelstein is a renowned health economist. I think she's probably she's arguably the best in the field right now and probably ever. You will see an interview she gave with Professor Galiani, a professor in the economics department here, in which they discuss her solution to how to fix the U.S. Healthcare system, which she says basically the problem with the U.S. healthcare system is that we have implicit insurance, right? That we pretend we don't give insurance to people. To a lot of people we give insurance to. In practice, we give everybody insurance, but in theory, we don't give insurance to everybody. And that creates a lot of strain on the system and a lot of problems. And if you gave everybody a baseline level of coverage, a lot of the problems would fix themselves. And so you'll see her make that proposal. But implicit insurance is really important for understanding the U.S. context in particular. And it really complicates the adverse selection and especially the moral hazard stories that we were telling earlier, right? Where all of a sudden, right, everybody's receiving more care than is optimal, maybe because we all have insurance, right? We're all taking more risks than we otherwise would because we all have insurance. And for what it's worth, I mean, Americans are notorious for taking risks. We're, compared to Europe, we're more likely to die in car accidents. We're more likely to get shot. We're more likely to do all sorts of dangerous things. We're more likely to be obese, right? Part of that might be that we all have this implicit insurance. Now, Europeans actually have better insurance than we do typically. But you might think like, oh, well, Americans have less insurance, so they should be less risky. Not necessarily true, right? Low-income Americans actually have, all Americans, even high-income Americans, as Lockwood showed, even high-income Americans still have pretty high levels of implicit insurance, right? The college-educated people who don't have insurance end up not paying most of their medical bills, right? That's remarkable. So that's all for this lecture. After this, I'm going to be giving lectures on sort of the demand market for physicians, as well as not the demand market, the supply of physicians. We're going to go over the supply of physicians and healthcare providers. We are also going to go over the hospital industry, right? I mentioned hospitals and that they lose a lot of money because they are. We effectively ask, in America, we effectively ask hospitals to also be insurance companies for people who don't have insurance. And then also, you will hear from a person who lived through implicit insurance personally, right? My friend Ian, who was shot in the face, and he thought he had lost health care, and he thought the coverage, even if he did have health care, he thought he had lost health insurance, and even if he did have health insurance, the hospital they took him to was out of network, so he shouldn't have been eligible for insurance, and nonetheless, he ended up not paying a dime for nearly $500,000 in medical expenses after he was shot in the face, and they had to reconstruct his face. You guys will also hear from somebody who sort of lived this and experienced having implicit insurance. All right, I will see you all later in the week.